Hi and welcome to Neurocare Academy. This is a feature presentation with Associate Professor Andre Brunoni, who's been good enough to join us from Sao Paulo, Brazil. Welcome, Andre.
Hi, Trevor. Hi. Thank you for inviting me. It's a pleasure to be here with you guys.
Excellent, excellent. No, it's fantastic to have you. And it's the end of the day there in Brazil at 6 p.m., 8 a.m. here in Melbourne, Australia, the next day. But look, we're very fortunate to have you, Andre, and we're looking forward to listening to you talk about brain stimulation in psychiatry, your personal view into its past, present, and future. Now, I know, Andre, you're the Associate Professor at the University of Sao Paulo Medical School, and also you're the Director in Service of Interdisciplinary Neuromodulation and Co-Director of ECT Service in the Clinic's Hospital. So, look, you've got a very major role there in Brazil, and one of the most, I guess, interesting and up-and-coming people in neuromodulation, researchers and clinicians in neuromodulation in the world. So it's fantastic to have you here today. And we've prepared a few questions for you. So you've got some slides in answer for that. So we'll start off with the first question. We'd like to know a little bit about each of the researchers that we talk to on Neurocare Academy. So I would like to know a little bit about where you were born and where you completed your university education.
Okay, so I have to say first that I'm very happy for this special invitation. It's also nice to talk a little bit about my career, not about only my scientific aspects, but also about my career. And this was also an interesting exercise for me to look back in the past and then comment a little bit about my trajectory. So first I would like to introduce my city. So I was born in 1981 in Sao Paulo. Sao Paulo is a very large city in South America. We have more than 10 million inhabitants. So it's really lots and lots of buildings. So I was born here and I was also raised in Sao Paulo, Brazil. I spent all my basically elementary and high school education in Sao Paulo. Then I went to medicine. So I'm a physician. I went to the University of Sao Paulo, which is a very traditional university here in Brazil. It's also very big. So everything in Brazil is very big and large. But we have like this beautiful building of the University of Sao Paulo, now in the middle of the city. And I went to medical school between 1999 and 2004. And then afterwards, I continued my education doing residency. Actually, I did 2 residencies. The first one was in internal medicine. And the second one was in psychiatry, also in the Clinic's Hospital, which is the main teaching hospital of the University of Sao Paulo.
Fantastic. Thanks, Andre. I've never been to Brazil, but I would love to get there at some stage in the future and meet you and have a look around. It's yeah, certainly. You've done a lot of education, many years, and look, it's really interesting to hear about your education and what you studied. So, if you wouldn't mind telling us a little bit more about that, what subjects you did in your PhD and the laboratory that you did your studies in. Could you tell us a little bit more about that?
Yeah, of course. And then I also have to add that I never been in Australia, but I'm looking forward to go in the future. Okay, and then continuing, this was basically my background in terms of medicine. And then I went, I have to say an important fact in my career. So while I was doing residency in psychiatry, I visited Professor Fragne's lab. Actually, he didn't have a laboratory at this time, so I visited Pascoal Leone's lab. Felipe was a postdoc there. But this was a very important step in my career. I went to Boston in 2008. So in January, it was winter, it was very cold, but it was a very warm experience as well, because that was my first contact with non-invasive brain stimulation. And I think in that moment, I decided first that I would do research in this line, and second, that I would be a researcher, so not only a clinician, but I would also dedicate myself and my career to clinical research as well. So just after I finished my medical residency in 2010, I went directly to do a PhD in neuroscience. So this is not so common here in Brazil. Usually people take a little bit more time between the psychiatry residency or residency and PhD, but I went directly. I continued doing my PhD at the University of Sao Paulo in the Institute of Psychology. And something that's very common here in Brazil is doing a sandwich PhD. So it's a funny name, but basically the idea is that you go and spend some time during your PhD, like an exchange program. And then I went back to Boston at Harvard Medical School. Now Felipe Fregni also already had a lab, and then I stayed almost 6 months there. It was also a very important step in my career.
Very good, thanks. Look, a really interesting history there with your studies, Andre. So obviously you went very quickly into research, and you've done a lot of the clinical work as well. And that's one of the main goals of Neurocare Academy also, is to try to bring the research to the clinic, to the clinicians, to the clinics, and make all of this research clinically applicable as quickly as possible. So we're going to ask you a few questions about that today, and also try to understand how this research that you're doing can be transferred. So, but to begin with, let's talk a little bit about your previous research in the field. Obviously, you went very quickly from school into doing your PhD and doing your research. So if you could give us some background there, that'd be fantastic. And throughout your explanation, not only of this question, but throughout the whole discussion and interview, we'll be trying to bring all of this information to the clinic and make it applicable. So so tell us a little bit about your previous research, because there's been some landmark studies that we all know about.
Yeah, that's true. And actually, I was very, of course, there was lots of efforts, but I was also very fortunate for being able to do such a nice PhD. It was a nice combination of many things. And one of them, I think, is like this combination of just being out of medical residence. So everything in terms of psychiatry was very fresh in my mind, and the questions that I had. And also non-invasive brain stimulation was very new and fresh as well, worldwide and also in Brazil. So I thought about combining these two things. And I had a special interest about mood disorders. Mood disorders, I personally think it's a fascinating set of disorders. And then we started, I started my PhD. My research question was about major depressive disorders. So just to remind our viewers, what is that? So major depressive disorder is basically a condition where people have two main symptoms, which are depressive mood and anhedonia, and they have lots of accessory symptoms such as anxiety, lack of libido, decreased concentration, weight changes. So as you can see here, these symptoms are very they bring lots of burden, and they are very incapacitating, disabling. They can really affect someone's life, and especially because usually people who have the first episode of major depressive disorder, they are in the early 20s, so it can be really disabling. And then the question that I had when I did psychiatry in my university, my medical school, was the issue of treatment resistance. So we were in 2010, and just about that time, they started the trial, or the study trials were being published. This study was a major trial that was done in the US in the beginning of this millennium. And they recruited more than 5,000 participants, and they wanted simply to try all possible antidepressant drugs to see which one would work best and what would be the side effects. So that was their idea, and because of that, they recruited lots of patients. And basically, they found uh, two main findings which were not exactly stimulating, they were kind of disappointing. So the first one was that they could not really identify one single antidepressant that would be better than the other ones. So they were basically the same in terms of efficacy. Of course, in some analysis, there was an indication that one type of antidepressant could be better than the other one, but the whole idea was that there was nothing more significant in terms of antidepressant drugs. And the second finding was that 30% of patients were treatment resistant. So basically, it didn't matter what kind of drug they used, 30% would be treatment resistant. And also thinking about this 70% who were not treatment resistant, many would drop out using antidepressant drugs later because of side effects. So I told you that people in the early 20s have the first depressive episode, and usually the side effects of antidepressant drugs are weight gain and also decreased libido. So really important symptoms of for young and for young men and women. Meanwhile, TDCS was being investigated, and it had some interesting features in terms of adverse effects and safety. So basically, and these were one of our first studies that I did in my PhD was a systematic review about adverse effects in TDCS. And we found that TDCS effects were mostly mild and well tolerated. So people had side effects such as itching, skin redness, tingling, and burning sensation, but they were very, very mild. And we didn't observe dropouts related to using TDCS, which was very different than antidepressant drugs. We also found in later studies that people didn't present serious adverse effects, such as seizures, for instance, which is a complication of TMS. And even the risk of hypomania and mania was very low. So it looks like that TDCS could be really used in clinical practice. And then, of course, thinking about other advantages, not only safety and tolerability, it is very non-expensive compared to TMS. I was also sensible to this question because Brazil is a middle-income country. So if we can develop a treatment that's not very expensive, this would be very important for other countries as well. We could foresee the possibility of using home use devices. This was not something real 10 years ago, but it is now. I will comment on that later on. And we want to study the effectiveness for depression, which was our big research question at that time. So basically, these were the ideas that I had in my mind. Uh, Depression being a terrible and disabling disease. Patients don't tolerate the adverse effects of antidepressants. Can we do better about this? And then could we use TDCS to help these patients? So that was what I had in mind at that time, and that's why we designed the SELECT-tDCS trial. So basically, we wanted to see or to compare TDCS versus antidepressant drug, but we also wanted to examine the combination of TDCS and antidepressant drugs. So how, what would be their effectiveness combined and separately. In order to do that, we did a clinical trial, so a randomized clinical trial recruiting 120 patients who were adults. They were moderately to severely depressed, and they were not using antidepressant drugs before the trial. So this is very important to avoid interactions between previous antidepressant use and TDCS. The interventions were 2 sertraline and 12 TDCS sessions, and you can see here that we did this in a factorial design. So people could be randomized to one of 4 groups: TDCS, sham, and placebo, TDCS, sham, and sertraline, active TDCS and placebo, and active TDCS and sertraline. So they were double blinded. They would not know what treatment they would receive. And basically, we found that the combination of TDCS and sertraline led to a faster and more effective response than each treatment alone. We can see here in the black line that there was a reduction of more than 50% in the severity of symptoms, and also at week 2, the combination of TDCS and sertraline was more effective than each treatment alone. At week 6, we also see that TDCS was superior to placebo. We can also see that TDCS and sertraline had the same efficacy. Of course, this result was a little bit more challenged. First, because as you can see here, sertraline was not superior to placebo, so this was not completely clear here. And also the dose of sertraline was low. It was only 1 pill, 50 milligrams per day, which is a low dose for treating patients. But basically, these were our findings. We were very happy for 2 reasons. First, it was published in JAMA Psychiatry, which is one of the most respected journals. I would say that's the dream of many PhD students to publish in this journal. And also when we had the acceptance, our finding was also published in the New York Times. And also this made us very, very happy. And as an indicative that TDCS was slowly becoming a mainstream treatment.
Great, Andre. Thanks for that explanation. I was just wondering what you did after your PhD. Was there something that you went on straight away from that point?
Yeah, so that was a decision that I did just after my PhD. So I completed it in 2013, as I said. So let me just show you. And then I had good opportunities here in Brazil as well. So I could return to the 2 hospitals that I used to work as a resident and as a physician with good positions. So I became both the head of the service of neuromodulation at the Institute of Psychiatry, the position that I hold until now, actually. And then I became a research group leader and PI of the SELECT-tDCS trial that I'm going to discuss later on. But this was in the same hospital that I did my PhD, and this was between 2013 to 2017. And so this period just after my PhD was very nice. I could do lots of things. So this was the period of being a young investigator. And I really enjoyed this time in my career. So I started being invited to go to conferences and lectures. And of course, there was a lot of research as well. And then I completed my education between 2007 and 2018 when I went to Munich. And of course, when you go to Munich, you go to Oktoberfest. So here I am in the upper right side. And of course, experiences like going to a very, very cold place, which is unusual for me as a Brazilian. But also it was a very important step in my career, like finishing my research education, my research track. And here I have to mention Professor Frank Battenberg, who was my host when I was there. And it was a very important experience, both personally and also in terms of research career.
Thanks, Andre. Well, it sounds like a very exciting time for you just after your PhD, Young Investigator Awards, traveling around the world. It must have been a really exciting time for you. So that's great. And then obviously you had all these ambitions and thoughts about what you would do after that. You had lots of different opportunities around the world as well. And so what did you end up choosing to do at that point? I know a little bit about your research. Obviously, I can't explain it in as much detail as you, and that's why we have you here today.
Okay.
But it's really like I've read a lot of your research, and I know that you're really focusing on 3 sort of research areas. And would you mind telling us a little bit about that, please?
Yeah, of course. So I found that I was well positioned to do a type of research focused on clinical trials because I was in a big hospital. I am in a big hospital in Brazil. I decided to stay in Brazil, and then I realized, or not only realized, but also for the reason that I perceived that I could do large clinical trials here in Brazil, because we have like a large city, as you could see, and a large hospital, and we could recruit many, many patients. And then that's why I was able to develop three main research lines. And the first one, I would say, is that we explored the efficacy of TDCS in unipolar depression, and then we first started with the interaction between TDCS and antidepressant drugs. We also started a second research line exploring the effects of TDCS in other disorders, also in terms of randomized clinical trials. And then our first study was the post-stroke depression, the efficacy of TDCS in post-stroke depression. And because I became the head of the Service of Neuromodulation at the Institute of Psychiatry, we had access to TMS there, and then we started doing RCTs there as well. And then the first example of this research line is the randomized clinical trial that we did evaluating the efficacy of deep TMS in bipolar depression. Then we had other studies, such as evaluating the efficacy of TDCS in bipolar depression, comparing the efficacy of TDCS versus antidepressant drugs in unipolar depression, then another study investigating the efficacy of TDCS in schizophrenia, and then in OCD, and I'm going to comment some of them now. So the first one, or the main one, which was also very well published in the New England Journal of Medicine, we decided to compare the efficacy of TDCS versus an antidepressant drug. So as I was commenting with you, we found that TDCS plus sertraline was more effective than each treatment alone, but we were not so sure about the comparative efficacy between these two treatments. And that's why we decided to do the second study. This was a non-inferiority trial where we decided to compare TDCS versus escitalopram. Why escitalopram? Because it is one of the most effective drugs for depression, and we could use a large dose or a high dose of 20 milligrams per day very fast. So it's the maximum dose is very close to the initial dose. It's simply 10 and 20 milligrams. So it was easy to achieve maximal dose. And then the non-inferiority aspect was to establish that the efficacy of TDCS would be at least 50% of the efficacy of escitalopram compared to placebo. So TDCS had to achieve at least minimum of 50% of efficacy of escitalopram, which is pretty standard in the field. And we also had a placebo arm where we could index the relative efficacy between TDCS and escitalopram. Otherwise, we could do a comparison and, for instance, finding that TDCS and escitalopram both decreased 30% of symptoms, just an example, but we would not be able to say if they were both good or bad because we didn't have the placebo arm. So with this design, we could have the relative efficacy as well. So our main findings were that first escitalopram was superior to placebo, and then we estimate 50% of that, so 5.5, 50% is 2.75, and then we plotted the relative efficacy of escitalopram versus TDCS. We saw that the non-inferiority margin crossed the lower bound of the confidence interval crossed the non-inferiority margin. As we can see here, the lower boundary of the confidence interval was 4.3 and the non-inferiority margin was 2.75. As this interval was crossed, then we concluded that TDCS was not non-inferior to escitalopram. And as we can see here on the left in the superiority analysis, actually escitalopram was superior to TDCS. However, we also found that TDCS was superior to placebo. And then we could establish that the efficacy of TDCS must be something, of course, it's higher than placebo, and this is important because placebo has a strong effect in depression, so it was above that, but it was not better than escitalopram. And one of my current research lines is trying to understand this better, as I'm going to explain this later. However, even with this finding, other people, of course, around the world also did many clinical trials about depression. We did a very recent meta-analysis synthesizing the efficacy of TDCS with 23 randomized clinical trials, more than 1,000 patients, and we could find actually that TDCS was superior to placebo in all endpoints in terms of depression improvement, in terms of response and remission. So really consolidating the efficacy of TDCS in depression. When we did a review, so this with Felipe Fregni and many other authors, this is a very interesting review actually, because it was not only focused on depression, but in all types of neurological and psychiatric disorder. But on depression, we could find that TDCS was definitely effective for treating depression based on all literature, not only based on our studies, but based on all studies published. And then here I can give you a real world example. So for instance, this is something that we are doing very recently. So using, let me show first the protocol. So it's a home use TDCS device where we do 2 milliamps, 30 minutes per day over the prefrontal cortex. This is combined with a app-based behavior therapy app that also gives psychoeducation to the patient. So they use an app, and then they have like tips about psychoeducation, and they have some advices like to improve the quality of their life. So it's a kind of behavioral intervention. And we did 24 sessions during 6 weeks. Here is an example of patients who all of them had depression. You can see it's like a real world example. All of them had comorbidities. 3 of them had generalized anxiety disorder, which is very common in combination with depression. 1 of them also had social anxiety disorder. 1 of them also had OCD. Male, female with different ages. So a really common sample that we see in clinical practice. And we actually had nice findings. Of course, this is very pilot, only 5 patients, but we could see that all of them were moderately depressed, and after 6 weeks, 4 had a very nice pattern of response. Actually, 3 out of 5 remitted. A 4th one almost remitted. So basically, she's also in the remission field here, and only 1 patient did not remit. But also interesting that this patient had OCD, and we also know that OCD is much harder to treat. Maybe this is nothing again because it's only 5 patients, but this is also an indicative of some nice findings with TDCS, and we are really excited about the possibility of using TDCS at home. The other trials that we did, as I mentioned, so in post-stroke depression, this was my PhD student, Leandro Valhengo, and we could find that TDCS was superior to sham in terms of post-stroke depression. A phase 2 study. In another study that we did, a randomized clinical trial, this with Bernardo, who was also my PhD student, we could find that TDCS was superior to sham in bipolar depression. So very similar protocols, 12 sessions, 2 milliamps per day, 30 minutes per day per session over the prefrontal cortex. And in new trials that we did now, not in the field of mood disorders, but in schizophrenia, we found that TDCS was also superior to sham in terms of negative symptoms of schizophrenia. This was also led by Leandro Valhengo. And in a final study that we just published, and Renata was the first author, we did in OCD, obsessive compulsive disorder, with 43 patients. This was a more intensive protocol with 20 sessions of TDCS. and we found that TDCS was also superior to sham. Also interesting, for these two disorders, we did not expect early efficacy. So we did not have an endpoint at week 6, but then at week 12, because these disorders are more severe. And then we thought that it would take more time for TDCS being effective, and we could actually prove our hypothesis. Then continuing about my research lines, later on we did a network meta-analysis of TMS and depression. This was also one important study that we could do. Basically, we combined all RCT studies using TMS, but in a network meta-analysis sort of way, which is a kind of different meta-analysis. Usually we only do the comparison between one intervention and placebo. This is called pairwise or standard meta-analysis. But in the network meta-analysis, we are able to investigate also the indirect comparison. So for instance, we have bilateral, sorry, it's in Portuguese here, but we have bilateral TMS here. We have sham TMS here. And then we can extract the evidence not only between TMS and sham, but also between all other modalities of TMS. So that's really the strength about the network meta-analysis. We can do all direct and also indirect comparisons. And then we could find that low frequency TMS, high frequency TMS, TBS, bilateral TMS, and priming TMS were superior to placebo, but not deep TMS, accelerated TMS, and synchronized TMS. So this was also helpful in the field, and also helped in the establishment of guidelines or clinical practice, not only in our group, but also worldwide.
Yeah, fantastic, Andre, and it's really important to see that in a lot of your research you have. Well, it's really nice to know that a lot of the samples, the participants are real world participants, and can give us information on something that's probably pretty close to what we see in a real world sort of environment, which I know is one of your goals. So how would you use some of this research, all these findings over the past 10 years in this brilliant research that you've just shown us? Are you beginning to apply that in your own clinical practice? And what sort of how can you use this knowledge? And speaking to those clinicians who are watching today, how can they use some of this in their own clinical practice, do you think?
Yeah, so Trevor, this is actually a very important question to answer, how we apply all these things in clinical practice, right? Then I really have to mention first, so first is one, but I really have to mention two TMS studies that are very important in my opinion, because they are really also pushing the field forward or moving the field forward. The first one is the 3D study, which is a study that was done in Canada, where they recruited more than 400 patients. So this was very large, and especially for TMS and non-invasive brain stimulation standards. But then they had the research question of whether TBS would be as effective as the traditional 10 Hertz TMS. It was a non-inferiority study. And basically, what's the big advantage? It's that in clinical practice, you can do a TBS session in 3 minutes and not in 37.5 minutes, which is the FDA approved, or it was the FDA approved parameter. And they basically could find that both interventions, the 3-minute TBS and the almost 40 minutes TMS, had the same efficacy. And because of that, TBS was approved for treatment in depression. And of course, then the second question is, if the patient can do one session 3 minutes, why don't we do like 10 sessions per day if it's so fast? And then exactly this was the second study. So first I have to highlight that I just showed a randomized clinical trial with 400 patients. This is a very pilot study with 30 patients, more or less. But it's also very interesting because they this scientist study did basically that. Instead of doing only 1 session per day, they did 10 sessions per day for 5 days. So in 5 days, they did 50 sessions of TBS. And basically what they found is that after 1 week, patients went for a score of MADRS, which is a depression rate scale of 35 to less than 10. So basically, almost 90% of them achieved remission. And of course, this is not a sham controlled trial. They only had 20, 30 patients. It's very preliminary, but I think that's also important to mention, also foreseeing the future. And then commenting a little bit about clinical practice, I mentioned TDCS as a real world example, but because TDCS is not really approved in Brazil, this is changing fast, very fast. So in 2021, this year, actually, we expect that TDCS is approved as a treatment for depression in Brazil. But because it's not, then we really don't use in clinical practice, only in research. But TMS has been approved for 9 years now. So we have actually a busy clinical practice service in our center. So I'm just showing a little bit of it here. We have 5 TMS machines. It's like a very nice place, not only to do research, but also to receive our patients. We do 10 sessions per day, 200 sessions per week, almost or more than 7,000 sessions per year over 8 years. And I have also to mention that we only had a single report of seizure. So again, highlighting that seizure is a very, very rare or uncommon event for TMS. Basically, we treat mostly psychiatric patients with depression. Then we develop our own protocols for depression. Basically, we started doing 15 sessions of high-frequency TMS over the left dorsolateral prefrontal cortex. We do the BEAM method. Neuronavigation is being discussed as the preferred method in terms of efficacy, but new studies or studies have also showed that the BEAM method is just as fine for clinical practice. And then we do 120% of the motor threshold. If the patient does or if the patient has depression comorbidity with generalized anxiety disorder, or if the patient has bipolar depression, then we do a different protocol. We started with low frequency TMS over the right dorsolateral prefrontal cortex. If the patient does not respond to any of these 2 treatments, then we do 10 to 15 sessions of bilateral TMS. So this is the protocol that we developed. And now we are slowly adapting our protocols for using TBS. We are still discussing if we do more than 1 session per day. Although we were very happy with the 3D study, we should also remember that TBS was not compared against placebo. So this might be no important issue, but in fact, it was not compared against placebo, which is a requirement for approving TBS in many places worldwide. So we are a little bit cautious about that. And in clinical practice, we are envisioning a goal that, so first I showed the STAR-D trial, which was basically a path for using antidepressant drugs, where they start with one antidepressant and then they combine the antidepressant with another drug or with psychotherapy and then so on until the patient receives ECT. But now I think we are also developing another path or another pathway where patient could start with TDCS and then combining TDCS with antidepressant drugs and then go then to TMS and then go to ECT. And me and other people in our field are really developing evidence on that. So for instance, the SELECT-tDCS trial showed that TDCS as a monotherapy is effective. And then in the second step, TDCS plus antidepressant drug is also effective for depression. And then in the third step, our network meta-analysis, but also these studies also showed that TMS is effective in depression. And then, of course, CCT, we know that's effective. But we are really developing a new clinical pathway for using neuromodulation in clinical practice, and that's one of our main goals, like adapting non-invasive brain stimulation clinical practice.
Thanks, Andre. Yeah, it's really important for us, us other researchers, people in the field, clinicians in particular, to know that researchers and clinicians like yourself who are very experienced in neuromodulation, both TDCS and TMS, are trialing all of these different methods, the different protocols, so that when it becomes approved and evidence-based, we know that people who have done it for years, you've been doing this in your clinic for 10 years, it gives us the surety that all of these protocols have been tested. So it takes a while for this for these protocols to come through. And I know that you're doing the clinical trials, you're doing the research. What's the focus of your current research now, so that we can, I guess, not only use the evidence-based protocols, but start to begin to use these protocols that you're trialing in your clinic as well? And how do you see the potential translation of what you're doing into things that we can use over the next 10 years?
Yeah, so that's again very important question, and then that's like the present and the future. That's me in the present, much older than the first pictures, but I'm still here. And of course, as a physician or as a psychiatrist and physician, then my question is always, how can we improve our patients' lives? So that's one of my main drives in doing clinical research. But now I would add new questions which are in the framework of precision neuromodulation. So we can see that the field developed a lot. When I first started going to conferences or symposium in 2010, then we were in a very exotic rooms, almost outside of the building, and now it's really mainstream neuromodulation. But because of that, we also have much more complex research questions than we used to have in the beginning. And now in this concept of precision neuromodulation, we have this question. So as you can see here, TDCS, TMS, and TCT, they work, but we could do better than that, right? So how, of course, we can always improve the efficacy, but how can we do that? The second, or not in a rank, but another question would be, could biomarkers help? There are lots of discussion about using biomarkers in psychiatry. Could they also help in neuromodulation? And then I think especially for neuromodulation, biomarkers would be helpful because we are directly targeting the brain instead of taking a pill, which is much more complex in terms of metabolism, and you have to consider the body metabolism as well. But for brain stimulation, I think they would be really, really helpful. And then again, related question is, can we predict the response of people who are using TDCS and TMS? Because of course, the disadvantage of TMS, for instance, is that the patient has to go to the clinic every day instead of taking a pill where people can only return to the hospital every month, for instance. So how can we predict the response of them? Could TDCS be escalated? This is another question. Can we accelerate TMS response? Can we further improve VCT, making it effective but without its side effects? So these are the questions that I don't have an answer, but which are in my mind right now. The question of trying to predict the response of TDCS, we are starting to answer it, and using the data from our SELECT-tDCS trial. So we were also very fortunate because we recruited 245 patients and we had TDCS and escitalopram. So we can really compare the efficacy between them, not only at the group level, but also at the individual level, which is important for making predictions. And then we develop many studies predicting response and evaluating biomarkers. I will, of course, not comment all of them, but I will comment some studies that were particularly important thinking about precision neuromodulation. One of them is that we tried to predict treatment response using a machine learning framework. So I'm not going into the details of the machine learning. Basically, we use a state-of-the-art algorithm to predict response. Another important aspect is that we use only baseline data. So it was just like a patient sitting in front of me, and I'm doing like a regular anamnesis, asking him questions about about depression, about their clinical questions, and after the end of my interview, I would try to figure out whether this patient could receive escitalopram or TDCS, which is the things we do as psychiatrists, right? Uh, but then we use this machine learning framework, more trying to predict that in a more data-driven way. We basically, there were not super results in terms of prediction, but I'm highlighting here that the predictors of TDCS and escitalopram were very different. And then here we can see the comparison side by side. So basically for TDCS, negative affect was the single most important predictor. And also positive affect and the number of depressive episodes were important predictors. But for escitalopram, many clinical features were predictors, such as body mass index, obesity, trait anxiety, negative affect, clinical scales, neuropsychological scales. And I think these relate also with my comment that TDCS is much more focused in the brain compared to escitalopram, which involves the whole body, like not only the brain, but also the body. So many other clinical features would influence escitalopram, and for TDCS, only these features, which are also related to a specific part of the brain, which is the prefrontal cortex. So I think this was important when we think about personalizing TDCS. We went further in identifying predictors of response for TDCS. So this was another analysis that we did, and trying to think about trajectories. So again, at baseline, what's the proportion of patients who will not respond, who will present a slow response, and who will present a rapid response. And we could also see that almost or a little bit more than 40% of patients will present a fast response with TDCS. We can see that as early as week 3, they will present a sustained and fast response. So this is also something that can be helpful in clinical practice. So, for instance, that we expect that almost 40% of patients would present a fast response for TDCS, and this can guide clinicians when using and deciding whether or not using TDCS. And also we could identify different predictors comparing trajectories. So for instance, we could see that comparing, for instance, rapid versus slow trajectories, then use of benzodiazepine was very important. When comparing rapid versus no or minimal response, we could see that age was important. And when comparing slow versus no response, we could see again that age and depression severity was important. So not only predicting in terms of response, yes or no, but predicting in terms of trajectory. So giving more fine-grained information about the effects of TDCS. Another study that's under review, and this one I particularly like very, very much, because we further examine the question of the construct of depression. So in the very beginning, I commented that depression had two main symptoms and accessory symptoms, but this also makes depression a very heterogeneous disorder. So we can have like 3 people with depression, they would have very little overlap between the symptoms. So I can have one patient with severe suicidality and another one with more anxiety and other one not sleeping very well. So very different symptoms. And then the question is, well, could we find a group of patients that would respond better to DCS? And then we tried to answer this question, and we could find actually that first, that the core depression, so mood, sad mood, so sadness and loss of interest, TDCS was effective, was better than placebo, and the escitalopram was also better than placebo. But we could see that, for instance, for guilt and anxiety, TDCS was not very good. Escitalopram was better. On the other hand, for sleep and insomnia, TDCS was better than escitalopram. That's why I like this study, because it is the first one showing evidence that TDCS could be better than escitalopram for specific groups of symptoms, which is sleep and insomnia. So maybe this can also guide clinicians. So in the future, if you have one patient with depression and more guilt and anxiety symptoms, so give him an antidepressant drug. Or on the other hand, if you have a patient with TDCS and problems with sleeping, then TDCS would be better than escitalopram. So I think that's really helpful in terms of prediction. We also examined some biomarkers, and we could find two of them which are of particular interest. So one of them is a study that we did with structural neuroimaging, and we could find that the volume or the size of the prefrontal cortex predicted TDCS response, but not escitalopram response. So specifically, people who had larger volumes of the prefrontal cortex presented a larger response for TDCS. And this makes sense because we do TDCS over the prefrontal cortex, and escitalopram, you don't stimulate the prefrontal cortex, you do everything. So this again indicating some differences or some specificity between TDCS and escitalopram. They are both treatments for depression, but they are not the same type of treatment. And this is one thing that our field, our neuromodulation field, is really showing in psychiatry. And then a follow-up study, now not using neuroimaging, but using simulation of electrical field. And I think this is nice in two aspects. So here on the left, you can see the simulation of the electrical fields in 16 patients who received TDCS, or in 16 MRIs, neuroimaging MRI of these patients. The electrodes were always placed in the same position, but you can see the huge variation. So you can see here, in this brain, for instance, there was a huge activation of the brain, whereas, for instance, here there was almost no activation. So in all cases, TDCS was placed in the same position, but for some patients, huge activation, for other patients, no activation. And why is that? Because there is individual neuroanatomic differences between these patients. In the second question, okay, does this really matter, or it's just like an artifact or an epiphenomenon, as we say? It does matter. So there is an association between more activation, more strength in the electrical field, and greater decreasing or more decreasing of symptoms of depression, anxiety. So the higher the electrical field over the prefrontal cortex, the higher the reduction in depression and anxiety symptoms. So this is something also indicating towards precision or adjusting the parameters of TDCS for achieving a higher response in depression. A little bit about the researches that we are doing now. I didn't comment anything about ECT, but this is one big trial that we are starting, so I think it's also important to mention. And basically, we have two large clinical trials that were just approved by FAPESP, which is a large research foundation here in Brazil. The first one is a randomized clinical trial with 100 MDD patients who are ECT eligible, so they are very severe patients, and they are being randomized for ECT or magnetic seizure therapy. So magnetic seizure therapy is a modification of TMS basically you use a TMS device, but to induce a seizure. And then you use like a very high frequency, a very high pulse. It's like different parameters, but importantly is an electromagnetic field. And the important aspect here is that this electromagnetic field can induce seizures in the prefrontal cortex, but they would not reach the hippocampus. So, and therefore, the hypothesis would be that it would have the same efficacy as ECT, but with less side effects because it doesn't reach the hippocampus, and the hippocampus is responsible for memory and for some cognitive functioning that is affected with ECT, but not with MST. So in terms of design, it's an interesting design. Similarly, non-inferiority in terms of efficacy, but superiority of MCT versus ECT in terms of cognitive effects. And we are very looking forward to start this trial. And the second one is the SELECT study. So following SELECT, ELECT, and now the SELECT study, where we want to recruit 210 patients with moderate depression. So this is in the other side of the spectrum. ECT, very severe patients, TDCS, much less severe patients. And then we are randomizing to 3 groups: home use TDCS plus active behavior therapy, home use TDCS plus sham behavior therapy or simulated behavior therapy. Basically, they will not receive the psychoeducational content, and sham. And then our hypothesis is that the combination of TDCS plus behavior therapy would be better than TDCS alone, and TDCS alone would be better than sham. So these are the 2 big trials that we hope we can start in 2020.
That's fantastic, Andre. Thank you very much. And obviously, a lot of that current research that you're doing is going to be clinically applicable for us, enabling us to make decision rules along the way. If this is the presentation of the client, then this. And there's also brain imaging that you have there that can help inform our decision making, so that we can personalize interventions and we can optimize the treatment efficacy. So really, these are really important studies that you're doing, and it's fantastic. So what are your future research aspirations? Just to finish off this interview, I think a last question: what are you going to be doing? What are you focusing on in the future?
Yeah, so that's a very important question. So how I see the future, I think I talked a little bit about my pure research perspectives, and then this would be, of course, further advancing the field in terms of precision neuromodulation. And of course, we have this vocational, or this role here in this vocation here in Brazil, and the ability for doing large clinical trials. And of course, we want to do that because we have this expertise, right? I mean, doing clinical trials is not an easy task. There are lots of details in terms of doing not only a proper randomization, but the blinding is very subtle and complex for non-invasive brain stimulation. You have to develop the proper ways for doing blinding. Also, like, recruitment is hard. It's harder for neuromodulation. Avoiding dropouts is harder for neuromodulation because people have to go every day. And now there is this new challenge for basically conducting almost a digital trial, because in this SELECT that I just mentioned, we might only see patients twice, at the beginning and at the end. Everything else will be done remotely, which is also very challenging because there is really no precedent about how to conduct a trial this way. So these are things that are challenging, but also very exciting for a researcher. But thinking about a little bit about a personal aspect. Of course, when we talk about Brazil, the country is in a hard moment nowadays, and there are some difficult things about developing an academic career in Brazil. Maybe not so much for me, because now I have a position at the university. which is a tenured, stable position, but also for people who are young investigators. But I would also like to say that there are positive and negative aspects at every country. So I mentioned, for instance, a positive aspect of being able to do clinical trials here with lots of patients. Some aspects are easy to do here compared to Europe and the US, and I can say that because I have both experience. And of course, moving abroad versus staying in your own country, it's also personal reasons, opportunities abroad, and local opportunities as well. So we always have to balance that. And I would say that not only personally, but also in terms of career, it has been a very good moment for me. I returned to Brazil at the end of 2018. I was in Munich, then I returned here. So I'm beginning my new position as a professor in 2019. And I'm also having new or exciting new experiences as a associate professor here. So supervising undergrad, PhD, and postdocs. I have more freedom now for acting as a PI and doing grant applications, roles at the medical school. When you start to become older and more senior, then you go to committees, working groups as well. But you also you are also part of the community of the university, which is also nice. In the teaching activities, of course, I know that many researchers don't like to do teaching activities. I like to do very modestly, so but a few hours per week I think is important, also because it gives you ideas about what to do in terms of research. And I would say that coincidence or not, when I arrived here in 2019 and 2020, I was pointed out as a highly cited researcher by the Web of Science Clarivate Analytics, which is a very prestigious appointment or indication. So, for instance, in my university, only 2 people in the medical school were appointed as top researchers, and I was one of them. So, of course, we never know what the future reserves to us, but I'm happy here, and then my main idea would be continuing doing my work here and my job here. And then I would like also to thank you Neuro Academy for inviting me. It was a very nice opportunity to talk not only about my research but also about me. It was a very reflexive lecture also for me. Thank you.
Thanks, Andre. Look, that's brilliant. We're very honoured to have you as a part of NeuroCare Academy, and
Yeah, it
thank
was
you for
very
your
nice.
time.
Okay.
Okay, thank you very much.
Thank you. So have a good day then.
Bye bye.
Bye bye.